can have our next lecture now by Edwards, who's going to talk to us today about ERAS, Enhanced Recovery After Surgery. Thank you very much.
Thank you, doctors. I somehow like Kuwait a lot. Myself, my distributor partners here, Najmat Burgan, both are very thankful to you all to give us this opportunity to speak to you and present as to what we do to improve patient care and support what you are doing. Oh, sure. Yeah, it's working. I would like to present some of the key products that we have, and the future of most of the products would be based on this platform, which we call it as EV1000, which would tell you what and where and when it could be done to improve patient care. We call it EV1000 clinical platform. Over the last 40 years, we have been associated with your specialty, doctor, and starting from Swan Guns, where they helped us bring in the first hemodynamic monitoring catheter, Swans, till continuation that we had after that in, is that not working? Oh, that closer. Yeah, thank you. So that's the voice in the morning. So then after Swan Guns, we brought in 2005 flow track catheter, which was based on arterial waveforms, and moved on to bring in extravascular lung water VolumeView, and recently launched a catheter which is the clear site, which works on just a non-invasive finger cuff technology. I'll be taking you subsequently to most of these products that we have. As this was a pediatric session, I wanted to show you the PediaSat catheter, doctor, which is what we have for the beautiful children around us. It measures continuously SCVO2 from especially for congenital disease patients, septic patients. It comes in different sizes, 4 French and 5 French catheter, and different lengths of 5 and 8 centimeter. The adult one is mostly informed, and you also had the adult catheter, which is 20 centimeters PreSep catheter. The pediatric one is new to Kuwait. SCVO2, the 4 factors that affect SCVO2, cardiac output, hemoglobin, VO2, and SaO2, we are all informed about it. Moving on from SCVO2, we also can measure SpO2, the mixed venous oxygen saturation, on a continuous basis from our advanced Swan Guns catheter, along with continuous cardiac output and right ventricular end diastolic volume when it's connected to the Vigilance 2 monitor. We would be introducing the VolumeView system in Kuwait, which would work on a transpulmonary thermodilution technique. And once we do a transpulmonary thermodilution, we get a thermodilution washout curve. You look at the curves, you choose the best of the 3, and an average is taken, and you get volumetric information like extravascular lung water, global end diastolic volume, and in animation forms like that. So 7 ml and above is higher, and so you can see different levels of animation here. Doctor, something new that will also be added, if you could see here, we have the cascade of information that starts from SCVO2 to DO2, VO2, and then we know that SpO2 would be affected by lung water, and we are giving you an additional information that if you had an extravascular lung water, would it be because of, acute lung injury, or is it because of congestive heart failure? So PVPI, if it's more than 3, it could be because of acute lung injury. So that's the new information that would be available on EV1000 monitors. Moving on from invasive to non-invasive technology, the finger cuff technology that I was talking to you about was launched way back in 1967, called the volume clamp method. It was commercialized by a brand called NextFin. If you Google it, that's the brand that has got the maximum amount of research around volume clamp method, finding non-invasive blood pressure and flow information. Edwards took over this technology in 2014. We polished the software after that, and we have introduced it recently. It gives you non-invasive blood pressure continuously along with flow information. The way you see the information is this way, doctor. You see a continuous arterial trace up there, real-time arterial trace, along with map information and cardiac output, cardiac index, and dynamic response information like fluid responsiveness, like stroke volume variation as well. All the information non-invasively. Quickly, with respect of time, we have an infrared light that passes across the finger to determine the diameter of the artery, and then without compressing the artery, the pressure required to hold the pressure is what is volume clamp. The pressure is transferred into a trace as a continuous trace. We calibrate the arterial tone, which might change due to various medication that's given to the patient. We calibrate from 10 seconds to 70 seconds. We understand the different shapes of arterial waveform, so the monitor transfers the finger pressure trace back into a brachial trace, and then we also do an adjustment for the height where we are measuring. We are measuring it at the finger and not at the heart level, so we also do an adjustment for the different height at which we are measuring through a heart reference system, so that there is no variance if the patient is moving his hand up and down. It adjusts as you can see it on the screen. The monitoring or the measurement technique is not the same like that of flow track. It doesn't just look at systolic minus diastolic like how we used to happen in pulse contour. Here it looks as the systolic pressure curve, and then it divides it by an afterload or resistance, which is measured based on patient's demographics, doctor. So it's slightly different from what we do with flow track, the measurement technique. I'm stressing on this because subsequently you will see newer developments based on this way of measuring. What's new, doctor, is based on this recent study published in 2016, which said that the retrospective study said that patients, if they were under a MAP of 65 and in a non-cardiac surgery, the longer duration that they were under hypotension, the risk of myocardial injury was higher. So with this as a background, Edwards would now be bringing in something called as HPI, which is called the hypotension predictability. So which is new, which is going to come in, whereby we will be able to predict, you will be able to get an information from the monitor that in the next 15 minutes, 67% to 85% or whatever, based on the percentage, higher the percentage, the patient is most likely to get hypotensive. So that's going to be the way it's going to go in future. We'll also be able to tell you what is the secondary factors for this hypotension. Is it because of fluid? Is it because of contractility? Or is it because of afterload, doctor? So that's the way it's going to go forward. So how do we do all of that? Edwards tries to join hands with you for more clarity through bringing in very innovative screens that you have seen right from basics, so that it can be implemented properly by the nurses in terms of color, in terms of shape and cartoons or animations that we use on the monitoring screens. Simulation is what is available on our website. If you go to www.edwards.com, you have two types of simulation there, basic and a higher level one, which we call it as POPs. The third one is with live symposiums, whereby you can listen to internationally interesting speakers. You could ask them questions live. We had 2 webcasts recently done. And the last one is through innovation like this one of hypotension predictability. So these are the things that we do as a whole. Thank you. Any questions, doctor, or something for me? Or no questions, doctor. Thank you.